Diabetes from the biochemical point of view, not from clinical. We have to mention the clinical side, but mostly we're going to concentrate on the metabolism in diabetes. What happened to the metabolism when a person has diabetes? So if we want to define diabetes in general, what is the definition for diabetes? And after you remove your cell phone, you can define diabetes better. صح؟ Don't you agree? خصوصا إذا كان تليفونك أحمر. بيشوش على التفكير التليفون الأحمر. Okay, so yes, please.
You can't break down sugars. You have lactose.
So if someone don't know anything about medicine and they say they have diabetes, what is it? What is diabetes? Yes, so it is high blood sugar, hyperglycemia. Okay, so this is the common definition for diabetes. Okay, we have diabetes mellitus that we are going to talk about today, and we're going to talk about the two types of diabetes mellitus. What are the two types of diabetes? Type 1 and type 2. What were the old names for these two types? They used to call them insulin dependent or insulin independent. Now they changed. They call them type 1 and type 2. Do you know why they changed? They don't call them insulin dependent or insulin independent?
Maybe there's another broad views.
Yes?
Because type 1 eventually will need insulin because the pancreas will be exhausted.
So the type 1 is what?
May eventually need type 2, may eventually need...
Excellent, yes, excellent. Okay. So before they thought if a patient has type 1, خلاص, you must give him insulin. But if he has type 2, you don't need to give him insulin. But they found that eventually type 2 also patients will eventually need insulin. That's why they stopped this nomenclature, which is very correct, thank you. But that's why now they call them type 1 and type 2. What is the difference regarding insulin? If you want to talk about insulin, what is the difference in insulin level between type 1 and type 2? Yes?
In type 1, there is no insulin, I believe, and type 2 is normal, or even elevated.
Is what? Elevated?
Normal or might be elevated, I think.
Okay, so type 1, there is no insulin. Do you all agree?
Yes.
Okay, so in type 1, it's an autoimmune disorder. The beta cells are destroyed, and these are the cells that are responsible for the insulin production. So if we don't have the cells that produce insulin, then we will not have insulin. Okay? So type 1, no insulin. Okay? Type 2, do they have insulin?
Yes.
They have insulin.
Receptors are not responding.
Yes. So they have, they don't have the proper response of the body to insulin, so they have insulin resistance, okay? As a result of this resistance, the body has to make more and more insulin. So at certain level, yes, they might have increased level of insulin, but eventually the beta cells will not cope and they will have deficiency in the level of insulin because the body, the beta cells get tired over time, okay? So type 1, no insulin. Type 2, there is a deficiency in insulin caused by insulin resistance, okay? Which one has a genetic determinant in it? 1 or 2 or both?
Both. More than one.
Yes, please.
Majorly 1, but 2 is also genetically affected somewhat, but it is mainly type 1 diabetes.
So both.
Because type 2
Both.
diabetes is
Well, both of them.
required to be genetically affected.
Okay, so you all agree that both type 1 and type 2 has a genetic determinant?
Yes.
Yes, so both type 1 and type 2 is caused by a genetic factor. Okay? Type 1, it is genetic plus what's the other factor?
Environment.
Yes. So something in the environment that will trigger what? Autoimmune response. Okay? So in type 1, there is exposure early in life to a certain factor. It could be a virus, ya Mu'adh, we don't know. It could be anything in the environment that will trigger an autoimmune attack. So the body will stop recognizing the beta cells as self. Instead, it will be recognizing it as non-self and attacking the beta cells, destroying them. Okay? So there is autoimmune disorder in the type 1. Beside the genetic predisposition. Okay, so someone who has the genetic factor, certain genetic factor is multigenic, it's not single genic. You learned this in genetic, right? So there's not a single gene that causes diabetes. So there are multiple genes. If they are present and there is exposure to a certain environmental factor that will trigger the autoimmune response, then the patient will have type 1 diabetes. When is it usually happen? Early or late in life? Early in life, usually in childhood or puberty. Okay? This is type 1. In type 2, we said also there is a genetic factor, but what is the other factor?
Environment.
Yes, what is it in the environment?
Type 2?
Lifestyle. Okay? Excessive eating, lack of exercise, plus the genetic factor, they will lead to type 2 diabetes. Okay? But which one has the stronger genetic determinant?
Type 1.
From genetic, you learn, I've seen it in one of your slides. How do you know that this disease has a strong genetic determinant or weak genetic determinant? Based on which studies?
Shows early in life.
Okay, what else? If you want to see, if you know that there is a genetic factor and you want to see how strong the genetic determinant, which people do you study? Monozygotic twins, excellent. So study on monozygotic twins have actually shown that although both diseases have genetic determinant, type 2, you will be surprised because usually people used to believe the other way around. It's type 2 that has a stronger genetic determinant. Okay? So genetics play a role in both, but in type 2, the genetic factor is stronger. Okay? How do we know this? From monozygotic twins, from identical twins. Okay? Which one can you prevent? Type 1 or type 2?
2.
Type 2. How can you prevent it?
Healthy lifestyle.
Lifestyle. Okay, so if you have a patient, you measure their blood sugar and it's not yet diabetic, so the fasting blood sugar is not above 126, but it's still not 99. And there is a range, okay, between 100 and 126. So yes, this is pre-diabetic. So you know that this patient, if they continue eating and behaving the same way, eventually in a couple of years' time, they will have type 2 diabetes. And this is where you can advise them to change their lifestyle in order to prevent them from having type 2 diabetes. Is it only about the blood sugar? What is the consequence of someone who's having hyperglycemia for many years? What will they have? What are the serious complications?
Problems in the cornea, kidneys.
Yes, so they will have kidney failure. You will be surprised that many patients, many elderly in their 70s, die from kidney failure because of a lifelong, uncontrolled diabetes. They will have kidney failure eventually and die from kidney failure. Some will have amputation, some will have blindness, some will have heart attacks, stroke. So these all are complications of diabetes. When you have too much sugar sitting in your blood, okay, it will have many complications. It will lead to neuropathy, the nerves will be damaged, nephropathy, the kidney will be damaged, and it will have many, many complications. So it is a life-threatening disease that can be prevented by lifestyle changes. We're talking about type 2, of course. Okay, let's go through the slides one by one and see what else we need to cover. The most important thing to understand diabetes, because it's all about insulin. Okay, so the hyperglycemia is caused either because there is no insulin in type 1, or because the body is not responding to insulin and the insulin is not enough, and this is type 2, right? So it's all about insulin. So let us review the role of insulin. What is the importance of insulin? So insulin is secreted in our body in response to high blood sugar, right?
Yes.
So when we eat, the blood sugar goes up, then the beta cells will secrete insulin. What is the role of insulin?
Will decrease the blood sugar.
To lower the blood sugar, okay? And it is anabolic hormone because it is signaling the well-fed state, okay? So So in the well-fed state, do we store things or we break things?
Store.
Store. Okay, so we want to store the glucose as glycogen. That's why we are going to activate glycogen synthesis and we are going to inhibit glycogen degradation. We have enough sugar in our blood, therefore we are going to let this sugar enter our cells, the fat cells and the muscle cells. How they will take up the glucose? Via which transporter? GLUT4. And the number of GLUT4 is regulated via insulin. So if we don't have insulin, we will not have enough GLUT4, therefore the glucose will not enter inside these cells. Okay? So insulin will activate glycogen synthesis, will increase the uptake of glucose by the cells, it's going to inhibit glycogen degradation, and it's going to inhibit gluconeogenesis. Because we are well fed, we don't need more sugar. Okay, there is plenty of sugar in the blood. The liver doesn't need to make more sugar, so it's going to inhibit gluconeogenesis. Now try to imagine what's going to happen in the body of a patient with type 1 diabetes and no insulin. So what's going to happen?
High blood sugar remains.
Glycogen lysis.
Gluconeogenesis is going on and on and on and on, regardless whether the patient has eaten or not eaten. His liver is constantly making the glucose. What else?
Increase in ketone body.
Fat breakdown.
So the blood sugar will go up, right, as a result of this continuous gluconeogenesis. And also what's happening? Can the muscle cells and the adipose tissue make use of this sugar?
No.
No, the sugar cannot be sugar because we don't have enough GLUT4, right?
So they
So
will
the
be
sugar
thin.
is sitting there in the blood, not being used by the peripheral tissues, and the liver keep on making more sugar. So this is at the level of the carbohydrate metabolism. What about if we review the role of insulin on lipid metabolism? We said insulin is anabolic. So it is signaling the well-fed. When we are well-fed, this is the time to get fatter and fatter. So it's going to inhibit the enzyme that will mobilize the stored fat from adipose tissue. So insulin will inhibit the hormone-sensitive lipase. Okay? This is the enzyme that will mobilize the stored fat. Okay? And also to help the body make fat, insulin is going to activate the lipoprotein lipase. What do the lipoprotein lipase do?
Break down carbohydrates.
Break down what? Lipoproteins. It will break down the triglyceride that is inside the lipoprotein. And by doing so, what do we do?
Produce fatty acids.
Yes, so we are trying to take this fat out from the lipoproteins in order to put them where? In the adipose tissue. Okay? So insulin inhibit hormone-sensitive lipase and activate lipoprotein lipase. Let's go back to the type 1 diabetic patient with no insulin. What will happen to his fat metabolism? He has no insulin. So, if he has no insulin at all, so let's say a patient who is just diagnosed with type 1 or a patient with type 2 and either he hasn't been diagnosed yet or he has uncontrolled type 2, he's not complying to the treatment. So what will happen in their body with no insulin? What will happen to the lipid metabolism?
Increase.
They will lose weight because the fat is being mobilized because they don't have insulin to inhibit the hormone-sensitive lipase. So they are going to lose weight because the stored fat is mobilized in the absence of inhibition by insulin of the hormone-sensitive lipase. And what will happen to the triglyceride in their blood?
Increase.
It will increase because they don't have the lipoprotein lipase being activated by insulin. So whenever they eat, or even the fat that comes from their mobilized fat is all going to be circulating in their blood and they will have elevated level of triglycerides. Okay? Yes?
Are
Early in the disease, they are overweight, and this is the cause of type 2 diabetes. But if they've been having uncontrolled type 2 diabetes for a long time, this is when they start losing weight. Okay, so you see it in typical, patients. They start by being overweight, and this is what caused the type 2 diabetes, their obesity, in addition to the genetic factor, of course. But later, if they keep on doing, keep on eating, keep on not taking their drugs properly, they might have a sudden weight loss because of their uncontrolled diabetes. Okay? Yes?
If I don't have gene factor and I have a bad lifestyle, that means I wouldn't get diabetes?
If you don't have genetic predisposition, then even, not all obese people will eventually become diabetic if they don't have the genetic factor. We will see this at the end. Okay? So, to understand diabetes, you have to know that, there is a simple equation. You have insulin in it. If you take insulin out, then everything is going to be messed up, and you will see the hyperglycemia, the elevated lipid, and we will see the ketogenesis as we will explain later. Okay, let us start talking about the types in detail. So in type 1, we said it's an autoimmune disorder, and they need insulin, okay? Because they are at higher risk of having ketoacidosis, and we'll talk about this in detail. This is written here, but it's also explained here. So what's happening in type 1 diabetes? There is exposure to a trigger early in life, something in the environment. It could be a virus, nobody knows for sure. But once this trigger is on, the body starts recognizing the beta cells as non-self. So the body will attack the beta cells and they will be destroyed. When you will see the symptoms, when you have 10 to 20% of the beta cells left, this is when the symptoms appear. And it will take about 10 years from the start of the immunological trigger for the beta cells to be completely destroyed. Okay? And these patients, they don't have beta cells, so you have to give them insulin. This is type 1. So when they are usually diagnosed early in life, childhood or puberty, the patient will come to the ER, probably he had a flu or something, and he has severe signs of diabetes. What are the signs and symptoms of diabetes? So weight loss, what else?
Thirst.
Yes, excessive thirst, excessive urination, excessive hunger, and we will talk about them in detail. But first of all, let us review the genetic factor. We said that both type 1 and type 2 there is a genetic factor, but in type 2 the genetic factor is stronger, and this is what's based on study on monozygotic twins. So if a twin has one of the twin has type 1 diabetes, then there is a 30 to 50% chance that the second twin will have type 1 diabetes. But in type 2 diabetes, if one twin has type 2 diabetes, the second twin will almost eventually, later in life maybe, he will get type 2. So there is a higher chance for the monozygotic twin to get type 2 than type 1. This is how they know that the genetic determinant is stronger in type 2 compared to type 1. Okay?
Doctor?
Yes.
In diabetes, patients suffer from ketosis, right?
Yes, we are going to talk about ketoacidosis, yes. Okay, so the diagnosis we said for type 1, it's diagnosed early, and the patient will come with polyuria. What does polyuria mean?
Frequent urination.
Poly is frequent. Okay, uria for urination, so there's frequent urination. Polydipsia. في اثنين نايمين. ما بعرف أنا صوتي هيك nursery rhyme. What does dipsia mean? Thirst. Okay, they get thirsty. And there is polyphagia. Polyphagia, phago or phago, it's to swallow. شو يعني they swallow a lot?
They eat a lot.
They want to eat a lot. Excessive hunger. Okay? طيب, why is the polyuria?
Increasing glucose.
Okay, there's too much sugar in the blood and it will go in the urine. And when it goes in the urine, it's and take water with it.
Yes.
Okay? So that will trigger the polyuria. If they urinate a lot, then it will be thirsty. That will trigger the polydipsia. Why they have excessive hunger?
We all have it.
Because they can't use
Glucose
the-
utilized.
Okay, the glucose is not entering their cells, their muscle cells and their fat cells. So there are some cells which are deprived of glucose, and also the body is always using the resources in the body as a source of glucose. So everything is going to be depleted, so they will be hungry.
So it's a vicious cycle.
Sorry?
So it's a vicious cycle.
Yes, exactly, and we'll talk about it in more detail later. They will also have fatigue, weakness, weight loss. So do you diagnose them? You do the fasting. Fasting means like about 8 hours of fasting without eating. You measure their blood sugar. If it is above 126, then they are diabetic. You can also measure their HbA1c, which is the glycosylated or glycated hemoglobin. So the hemoglobin that we studied before, you know, that is inside your red blood cells, if it is sitting there with too much sugar around, then some of this hemoglobin will react with the sugar, and the glucose will bind to the hemoglobin protein, forming the glycated hemoglobin without an enzyme. So this HbA1c, if it is more than 6.5, then it is an indication that the patient has diabetes, because the normal level should be less than 5.7%. And we'll talk about it also again in more detail. If you do a fasting blood sugar and you find that it's not normal, so it's above 100, but it hasn't reached 126, then the patient is pre-diabetic. What is very important to do with this patient?
Changing his lifestyle.
Yes, we need to advise them to change their lifestyle to avoid them, to prevent them from having type 2 diabetes. Okay? What are the results? What are the causes of these metabolic changes? It's basically because there is no insulin. So the metabolic changes are the same in type 1 and in type 2. But in type 1 they are more severe because there is no insulin. In type 2 there is some insulin. Okay? So the absence of insulin is going to affect the liver, the muscle, and the adipose tissue. Okay? They are going to cause hyperglycemia and ketoacidosis. Why hyperglycemia, we said? There is no insulin, right? So there is nothing to stop the liver from doing glucose. So gluconeogenesis is going on and on, non-stop. And also, the periphery is not using that sugar because we don't have enough GLUT4 because there is no insulin. So the blood sugar will go even up and up, okay? So the sugar in the blood is not being used by the periphery, by the muscle cells and adipose tissue, and the liver keep on making sugar. This is what will cause the hyperglycemia. And all of that because we don't have insulin. So this is regarding the hyperglycemia. What I want you to look at here is that the Krebs cycle will be affected. Why the Krebs cycle will be affected? Because the oxaloacetate is going to be busy making glucose. So the intermediates of the Krebs cycles are not going to be available, which is going to slow down the Krebs cycle, and this will lead to the accumulation of
Acetyl-CoA.
acetyl-CoA. If acetyl-CoA accumulate, what will happen? They will form ketone bodies. So the three ketone bodies are acetoacetate, hydroxybutyrate, and acetone.
La. Escape.
What does acetone cause in the breath of a patient with diabetes?
Smell like nail.
Yes, they will have this fruity smell, okay, from the acetone that will appear in their breath. Okay, we'll come back to this in more detail. So the ketosis is a result from increased acetyl-CoA. But why we have increased acetyl-CoA? Because of the increased mobilization of fat.
Oxaloacetate.
Why we have increased mobilization of fat? Because we can't inhibit the hormone-sensitive lipase. Okay? So the fats are being mobilized. This will lead to the production of acetyl-CoA. The Krebs cycle cannot cope with this amount of acetyl-CoA because the Krebs cycle intermediates are busy making sugar. So the acetyl-CoA will be changed into ketones. These ketones are acidic. That's why the patient can have ketoacidosis. It is very common in type 1 diabetes. So 25 to 40% of patients with type 1 diabetes will have ketoacidosis, and they might get when they first diagnosed, and they might get it later if they don't take the treatment properly or if they fall ill. So type 1 diabetes are at higher risk of ketoacidosis. In type 2, the risk of ketoacidosis is much lower. Why? Because they have some insulin in their body. So another metabolic change beside the hyperglycemia, beside the ketoacidosis or the ketosis, we have elevated level of triglyceride. Why we have elevated level of triglyceride? Because we don't have
the lipolipase.
the lipoprotein lipase. This is one, and also this fat that is being mobilized. Not all of it will either go to ketone bodies or will be used, for beta oxidation as acetyl-CoA. So what will happen with this fat that is mobilized is going to stay in the blood, packaged inside the lipoproteins. Okay? So the fat that is mobilized from the adipose tissue will sit in the blood, causing a high level of triglyceride in the blood of a patient with diabetes. Okay? So we have low, let me finish this point. So we have low level of lipoprotein lipase, okay, because we don't have enough insulin, and the fat that is being mobilized will stay inside the lipoprotein, mainly the chylomicrons and the VLDL, and this lipoprotein level will go up in the blood, causing what we call hypertriacylglycerolemia. Yes?
Type 2 diabetes. Only the muscles are affected.
Sorry?
Only the muscles are affected. The rest of the body is not affected, right?
You mean by what?
Because it's blood flow is
Yeah, the uptake of glucose by the fat cells and the muscle cells will be affected. Yes.
Other tissue will be fine.
Because only GLUT4 is insulin dependent, right? The other transporters are not insulin dependent. Only GLUT4 is insulin dependent. Yes.
Diabetes.
Okay. So this is the picture of the metabolic changes in a patient with diabetes. But by the way, they are the same in type 1 and type 2. The only difference is here. Okay? Here in type 1, there is no insulin. In type 2, there is some insulin and there is insulin resistance. So the body is not responding well to insulin. Okay, but it is exactly the same image. So because there is no insulin, what's happening? Who can explain to me this slide? So we said the three things. We have hyperglycemia, we have ketogenesis, and we have elevated triglyceride. All because there is no insulin. Can you explain to me why we have those three things?
Triglycerides and what?
Yes?
Elevated triglyceride because we can't inhibit the hormone system lipase. What else?
Okay, that's good, that's enough. So we have elevated triglyceride because we can't inhibit the hormone sensitive lipase, and what else?
Ketone bodies?
Because we don't have enough lipoprotein lipase to break down the triglyceride. So these two things will elevate the triglyceride in the blood. Okay, so this is one thing, the elevated triglyceride. What about the two other things? The hyperglycemia and the ketogenesis. Yes?
We have hyperglycemia because of two things. One, because the liver is constantly making glucose by glucose metalysis, it can't be stopped. And the body, the peripheral is not absorbing the glucose by the good transporters, therefore glucose remains in the blood and causes hyperglycemia.
Excellent. What's the third thing? We said the ketogenesis, which can lead to ketoacidosis. Why we have it? So many of you, which is good. يلا تفضل.
Because in the TCA cycle, the
Yeah.
intermediates will be busy in the making the gluconeogenesis,
Okay.
and this will increase the acetyl-CoA.
So acetyl-CoA will accumulate, and acetyl-CoA will form
Ketone bodies.
ketone bodies. Okay. And why we have too much acetyl-CoA to start with?
Oxaloacidity is used in gluconeogenesis.
Yeah, but why we have too much acetyl-CoA? Why the Krebs cycle is not coping? Why too much Krebs cycle?
Because we need ATP.
Because the fats are being mobilized. Okay, because we don't have the inhibition of the hormone-sensitive lipase. Okay, clear? So just remember insulin and what does it do to the body, and take insulin out, then you will understand what happened to the body of a patient with diabetes. And the difference, type 1, they have no insulin at all. Type 2, they have two things. They have insulin deficiency, so not enough insulin, and the body is resistant to insulin, doesn't listen to insulin, it's ignoring insulin. Like you sit here and I tell you study, you know, and you ignore me. So the same thing will happen in the body of a patient with diabetes, type 2 diabetes. Yes?
Diabetes, if I have no insulin, then wouldn't this increase the lipase in the muscle tissues?
Say it again.
Okay, insulin increases the lipase in the adipose and less in the muscle. So if I have no insulin, now the LPL in the muscle will increase.
I said the insulin has an effect on the 2 lipase, and it's opposing effect.
In the muscle with no insulin, the lipoprotein lipase will increase.
Lipoprotein lipase in the muscle? Do we have lipoprotein lipase in the muscle?
How will it take and relax into the muscle by lipoprotein lipase? But in the presence of insulin, there is no LPL.
You lost me. We can discuss this later. I don't know what the point you're trying to say. Okay. Is this clear?
Yes.
Okay. Let's move on. So we talked about HbA1c. So we said that it was going to give you not a reading, immediate reading about the blood sugar. It will tell you how was the blood sugar over the period of last 3 months. So why do you think it's the period of last 3 months?
It takes a while to produce it.
It's the lifespan of the red blood cells, right? And the red blood cells has the hemoglobin in it. And this hemoglobin sitting there for the last 3 months being exposed to the sugar. Okay? So when you measure the HbA1c, it's giving you an idea about the blood sugar over a period of 2 to 3 months, because of the lifespan of the red blood cells. Okay? So the red blood cells sitting there in the blood with their hemoglobin will start binding to the sugar, forming the HbA1c. Clear?
I didn't get it.
So it's important that if you have a patient and you want to know if the treatment is working for them, if they are taking the treatment well, or if you want to increase the dose, this is the importance of the HbA1c. So based on the HbA1c, you might want to increase the dose of the drug. You might want to give the patient a different treatment based on the HbA1c.
Doctor?
Yes.
No, the glucose in the is in the plasma, right? The
Yes.
how it's related to the hemoglobin?
Because the hemoglobin is in the presence of glucose. Actually, glucose will bind not only to hemoglobin, it's going to affect the different proteins in the body, not only hemoglobin, leading to all the neuropathy, nephropathy, because all the proteins will be damaged by the sugar. We'll talk about this later. Okay, so the diagnosis without the fasting blood sugar and the HbA1c, you can do the random. Random means not fasting. So if a patient comes to the ER and he's having other symptoms and they want to check their blood sugar, so this is called the random blood sugar. It's not like it could be high just because they have just eaten, but if it is like abnormally high, above 200, it might indicate that the patient is having diabetes, but you have to repeat the test when the patient is fasting. The other type of blood, so we have 3 types. We have the fasting, we have the random, we have the HbA1c, and we have the oral glucose tolerance test, OGTT. So this is usually done for pregnant women, where they give them a
75.
liquid to drink that has sugar, so 75 grams of sugar. They wait for 2 hours and they see how did the body respond to that sugar, okay? How the body did tolerate that sugar. So usually done for gestational diabetes, which is diabetes during pregnancy, okay? So the oral glucose tolerance test is done for pregnant women. Okay, the symptoms, we talked about the symptoms. We said the polyuria is due from the too much sugar in the blood, which will spill in the urine and takes water with it. So polyuria will lead to polydipsia, excessive thirst, and the hunger because the weight loss, and the hunger because the body is trying to make sugar all the time. Okay, the treatment. So how do you treat patients with type 1 diabetes? You have to give them insulin, okay? So they need once or twice injection of insulin. These days there are the pump, the insulin pump, okay? But I'm not sure if it is available here, but it's a recent, okay? And even with that, you cannot restore things back to normal. So you can control it, but you will not bring their blood sugars back to normal level. I will stop here and we'll continue tomorrow, inshallah.